Good evening, everybody. Welcome to this webinar at Believers Church Medical College and Hospital. October is Breast Cancer Awareness Month, and we have observed it quite solemnly, and we are ending on a very meaningful note with this webinar on breast cancer. And for that, we have an international speaker, and he is consultant clinical oncologist at Mount Vernon Cancer Center, East and North Herts, NHS, UK. Certified and trained in Gamma Knife, CyberKnife, GCP clinical trials, etc. He is the primary and sub-investigator in many clinical trials, including Optima, Realt, Persephone, etc. After completing his undergraduate in India, he went on to complete his MRCP from the Royal College of Physicians, UK, PG Diploma Oncology from the Institute of Cancer Research at the University of London, FRCR from the Royal College of Radiologists, Special Registration in Clinical Oncology from GMC, UK, and recently got his doctorate in medicine from the University of Hertfordshire, UK. After holding various positions at Surrey NHS Trust, North Middlesex Hospital, and St. Bartholomew's Hospital, and of course the famous L&D Hospital as well, he currently is the lead of neuro-oncology services and tutor at MVCC, and also a member of various other academic boards. With 17 international publications to his credit and a lot of other public appearances also, our speaker for the day is none other than Dr. Anup Vinayan, consultant clinical oncologist, Mount Vernon Cancer Center, East and North Herts, NHS, UK. A doyen in the making, a clinician, an oncologist, a radiologist, and whatnot. Welcome, Dr. Anup Vinayan, sir, for our international webinar. And the moderator for the day is our consultant medical oncologist, Dr. Abraham Samuel. After completing his undergraduate training at Alleppey Medical College, he went on to train in his MD at CMC Vellore and his DM at the prestigious Tata Memorial Hospital. He is with us, and he's a brilliant clinician. He's taken his time off to moderate this session. Welcome, Dr. Abraham Samuel. And in order to moderate this session, to give an overview and hand over to our luminary speaker, I call upon Dr. Abraham Samuel to take over from me. Dr. Abraham Samuel.
Good evening to everyone. Thank you, Dr. Jacob Jisuran, for the kind words and inviting me for moderating this session about recent advances, as well as how we treat a patient with breast cancer, especially during the COVID era. Thank you for inviting Dr. Anup Vinayan as a faculty for this talk. As we all know, October month is celebrated as Breast Cancer Awareness Month. As we all know, the cancer incidence is increasing worldwide. Initially, it was second only to cardiovascular mortality, cardiovascular disease in terms of the leading cause of mortality. The recent data shows that it is almost leveled with cardiovascular mortality disease, and in some high-income countries, it has already become a leading cause of mortality among patients. And the worldwide, as I told you, the estimated cancer incidence is around, in India, it's around 1 to 1.5 millions. And in the United States and other countries, it's almost become like 1.5 to 2 millions. And among the leading causes of cancer, breast cancer still highest among the breast women. It's almost in the Indian, as per the Globocan data of the Indian patients, it's almost 30%, especially in the women. And the recent studies, especially hospital-based and population-based data shows that the breast cancer, the cancer among women is around about 50%. And of that 50% cancer, still breast cancer is top. And previously, cervical cancer was the #1 cause of cancer among the women. And now breast cancer become the most common cause of cancer among women. So this highlights the importance of knowing how to manage a patient with breast cancer. And also another important point is that still 2/3 of women come with a locally advanced locally advanced disease, and only 1/3 come in the early stage disease. So as we know, the stage advances, the complexity of treatment involved, the cost as well as the morbidity and the mortality increases. So it is important to identify women, especially high-risk women, to advise them for to counsel or just to propagate regarding early detection with regards to screening of the disease. And also as we know that many psychological issues also there regarding the and some social stigmas involved in the diagnosis also important. So so in order to diagnose early as well as to screen population, it's important to educate women with awareness programs. That's why we took this October month as breast cancer awareness program month. So with this, I would like to invite Dr. Anup Vinayan. He will enlighten us regarding the recent advances in breast cancer management, as well as his experience in the United Kingdom about managing patients with breast cancer. It's my pleasure to welcome Dr. Anup Vinayan for this meeting.
Thank you very much, Abraham, and thank you very much. Thank you for such kind words or generous words from Dr. Jacobson. Even though being called as an international speaker, I would also like to be known as a local speaker. I've trained myself in in Kerala, in Trivandrum Medical College, and I've got a lot of colleagues who works among you guys at the moment, and at heart still a local person. That's what I would say. So. And again, can I welcome all of you who've actually decided to spend your time with us this on a Saturday evening. So I'll start sharing my screen, and then Abraham, I don't know, can you see the screen, Abraham? Oh, you guys can see the screen. So just to start with, again, my name is Anup, one of the oncology consultants at Mount Vernon Cancer Center in London, and I've trained, did my medical degree back in Trivandrum. So my disclosures to mainly conflict of interest is I've had a research fellowship supported by Roche and travel grant from Novartis and GenesisCare, and also had some honoraria, but there's no scientific conflicts of interest in anything that I'm going to talk here. So talking about breast cancer and updates of breast cancer in an hour it's a humongous task. So I don't think I'll, it's probably not wise to even try to tackle that whole thing. So what I thought I'll do is I'll just quickly go through about the incidences which Dr. Abraham Samuel already alluded to, and talk about what current management in different types of breast cancer, and also talk about some recent advances. And I've selected 3 trials in early breast cancer and also in metastatic breast cancer, which I thought would be relevant. It'd be really great to see your views on that later on, and also talk about, and then I'll talk about, with the COVID-19 pandemic, which we're all going through, how we adapted when COVID hit, the first wave hit us initially. In the end, I understand we'll open up the floor for question and answers. Okay, to start with, as we said, breast cancer is the most commonest cancer in women worldwide. And it is close second to only to lung cancer overall. And worldwide, around 2 million cases is reported worldwide per year. And death from breast cancer is supposed to be around 600,000 per year around the world. So early diagnosis and detection of the breast cancer becomes an important part. I would like to brag as an oncologist to talk about the benefits that we, as with radiation or with chemotherapy that we give. But I think the most important thing that is needed when we're looking at breast cancer management is early detection, and also the work done by the surgical colleagues. So in UK, we do have a breast cancer screening program where ladies from the 50 to 71 years of age is invited to have mammogram every 3 years. And this is actually with the aim that with early diagnosis, we can actually give them a possible curative treatment rather than actually waiting for an advanced stage where we would end up trying to palliate rather than actually trying to attempt to cure this patient. And the numbers that we notice that it's roughly around 1 life saved from breast cancer related death with every 200 mammogram done, which would roughly equate to around 1,300 lives saved per year, which is a significant number. There's also concerns about when we're talking about screening program, are we unnecessarily exposing patients to radiation, and also the risk of overtreatment in a very early stage breast cancer, which may not, in an elderly patient, which may not affect them significantly during their lifetime. Are we going through overtreatment? When we look at the management of breast cancer, there is a lot of factors that we've got to take into account before we make a decision about what is the best treatment that's needed for the patient. And it involves the disease factors like what is the size of the tumor, what is the lymph node status of tumor, what is the stage of tumor in terms of metastasis to other areas, and looking at histopathological subtypes, including grading, grade 1 to 3, as you all know, and looking at immunohistochemical markers like estrogen receptor, progesterone receptor, and HER2 receptor, which I'll go into a bit more detail in the next slide. We're also looking at gene expression profiling to make a decision regarding what is the optimal treatment for these patients nowadays. But those are the disease factors. But we can't actually, kind of not disregard the patient factors there. You can't make a decision about same decision about a patient who is actually in their 30s and also who is in their 80s. So age of the patient, fitness of the patient, and the comorbidities, which is the most important thing that we need to think about here, also need to be taken into account. Talking about the estrogen, progesterone, HER2 receptors, you probably would have heard about this a lot, and we've got people in the audience. It's when you look at estrogen, progesterone receptors, cells have estrogen progesterone receptors on the outside of the nucleus in breast cancer cells, and if they've got higher level of estrogen progesterone receptors, you can use, or in other words, estrogen. If you look at the picture on the right side, estrogen kind of acts as a key in that lock and stimulate the genes to proliferate and resulting in growth of the cancer cells. Looking at HER2, in some breast cancers, roughly around 1/3 of it, you'll have amplification of the HER2 receptors, which you can see on the cell surface on the second picture. And in those settings, we can use an antibody or an antibody drug conjugate to try and block those receptors, and thereby resulting in trying to stop the growth of that cell. Symptoms of the breast cancer, I think I'm not going to go into much details about it. It is mainly the lump or nipple discharge or change in shape of the breast is quite important. And I won't go into details on that. So coming back to the management. So we need a multimodality approach in terms of management of breast cancer, which is what is actually done. The diagnostic techniques like the radiology, what is needed with the mammogram or ultrasound or even breast MRI scan, histopathological advances, everything has contributed to the management of the treatment. And as I said, once we move to the surgery, radiotherapy, and systemic treatment, there is a variety of systemic treatment that is currently available, including endocrine therapy, systemic chemotherapy, as we call the standard systemic treatments, and also targeted therapies and immunotherapy is the new kid in the block in breast cancer management. Looking at the diagnostic techniques, I think clinical examination, most important thing I would say, and then we're looking at mammogram and ultrasound are the most commonly used diagnostic techniques in breast cancer. also moving to MRI scan of the breast, especially in young women who've got dense breasts. MRI scan becomes an important part of their diagnostic pathway. Coming to advanced diseases, PET-CT or again normal CT scan is being used more and more, and also bone scan to assess the extent of disease in the bones. In UK, in a lot of the centers, we've actually now started to use whole body MRI with diffusion sequences more in favor of the bone scan based on a couple of trials that we've actually done here, which I can go into detail if needed later on. So I thought I'd start with early breast cancer. And early breast cancer, a rough definition would be is where you've got the breast cancer which is not spread beyond the breast and also beyond the axillary lymph nodes. Aim of treatment in these circumstances is to try and achieve a possible cure, and also look at controlling the local disease and maintain the form and function of that patient, and to prevent local and distant relapse. Roughly in UK, the number of patients cured in early breast cancer would be in the range of around 77 to 78%. That's a rough estimate that's been quoted. The main treatment of early breast cancer, as I said, even though I would like to brag about the chemotherapy and radiotherapy, it's mainly the surgical resection becomes the most important part of the treatment, which is supported and enhanced by all the adjuvant therapy that is needed, radiotherapy, endocrine treatment, chemotherapy, or even HER2-directed treatment, which I will talk about. But that is dependent on the type of breast cancer that the patient has. So if you've had an ER-positive, HER2-negative tumors, endocrine treatment becomes a significant part of their treatment. But at the same time, if you've got HER2-amplified tumor, as I said earlier on, using HER2-directed drugs becomes an important part to try and achieve cure for these patients. So this is just a algorithm for early breast cancer management, which, and it looks a bit complicated. It's from ESMO. And what we normally say is that if you've got a smaller tumor, less than 2 centimeters, and is optimally surgically resectable, with the exception that there's not an aggressive phenotype like ER-negative, PR-negative, and HER2-negative tumor, or what we call as triple-negative tumors, or even a HER2-positive tumor. In those settings, going for a surgical resection or breast-conserving surgery would be the right approach in setting. And on the other hand, if the patient does not want to have breast conservation, or if the breast conservation is not technically possible, we do need to go through the surgical option of a mastectomy. The shift in paradigm over the last 10 years is looking for patients who are in the middle group, who've got a larger tumor where optimal surgery is not feasible. Currently, breast conservation is not possible, but patient would like to have a breast conservation possible. And also they've got aggressive phenotypes like a HER2-positive tumor with, or triple-negative tumor with axillary lymph node involvement. In those settings, a systemic induction therapy becomes an important factor, and that is being taken up more and more these days. And with the current data on HER2-directed therapy and the adjuvant HER2-directed treatment, that takes a significant priority there. So again, in those settings, we would recommend for systemic induction therapy followed by surgical resection, whichever is actually appropriate for that patient. We all know that systemic induction therapy does not increase the survival in those patients, but it would actually improve their, the two aspects. A, it would actually help in, improving the surgical outcome. And second thing is that it might give us a window of opportunity in looking at what the nature of this patient's cancer is like, because there is evidence to say that if we can achieve a complete response, a pathological complete response with the induction treatment at the time of surgery, those patients are likely to do better in the long run. So once the surgical treatment is done, then obviously postoperative or adjuvant therapy options are there, where it could be endocrine treatment based on if the patient's got ER-positive disease, chemotherapy based on the, again, the immunohistochemistry and also the size of the lesion and the lymph node involvement. And also HER2-directed treatment if the patients are, the tumor was HER2 positive. So sorry, I've just gone backwards, I think. Yeah. What again has changed in the last 10 years is looking at multi-gene panel assays. So in circumstances where we've got, where we have got a grade 3, a larger tumor, or a grade 2 and a larger tumor, which are node negative, where there is a concern regarding what is the benefit of patients having chemotherapy. People have now started to move towards using a multi-gene panel assay in these settings, whereby we can look at what is the benefit or likely benefit the patient might get from chemotherapy, rather than just using the standard ERPR, HER2, and Ki67 grading. We look at a genetic panel and looking at whether we can whether that can predict the benefit of patients having chemotherapy. So advantage is that you can pick out the patients who may not benefit from chemotherapy, and we can avoid them having the side effects which would come through these potential treatment. Yeah, so there are a few tests that are available at the moment called Oncotype, Mammoprint, Prosigna, Extra. In UK, we commonly use in node negative patients, we standardly use a test called Oncotype DX. So currently the guidelines is to use anyone who's got a T3 and grade 3 disease, which are ER positive, HER2 negative, or anyone who's got a more than 2 centimeter grade 2 tumor, which is again node negative. We would use Oncotype DX to assess the recurrence score, which would help us us and the patient in deciding whether an adjuvant chemotherapy option is needed. But where does the data for that come from? So the most important trial for that is called TAILORx trial, which looks at a 21 gene. This is the Oncotype DX test that's been used, which looks at a 21 gene expression assay in breast cancer. So they've selected patients who've got ER positive, HER2 negative, node negative patients, and looked at the recurrence score in these patients. From the previous studies, they've they used 25 assay rough cutoff in terms of benefits of chemotherapy. And when you look at the two different arms here, one is the dotted line is the endocrine treatment, and the red line is the chemotherapy arm. And as you can see, there is practically no difference in terms of invasive disease-free survival or freedom from distant relapse in these patients. So that brings about an important factor to saying that we can avoid chemotherapy in a significant number of patients. One of the studies that we did, which is published as well, and showing that by using these tests, we can sometimes, in these patients in the intermediate risk category, we can avoid nearly 74% of patients having chemotherapy. And also, some patients who are reluctant to have treatment, when they see that the risk score is higher, that does actually put it into perspective for them to decide whether they should accept the treatment or not that we offer. So with that, I will actually go through some recent high impact trial results, which I presume will change practice in an adjuvant setting. First of all, I wanted to talk about this trial called Monarch-E. Monarch-E is looking at a drug called abemaciclib, which is a group of drugs called CDK4/6 inhibitor, it's a cell cycle inhibitor. I'll quickly go there. So this is actually, there are 3 drugs which is currently available looking at a cyclin-dependent kinase 4 and 6 inhibitor. They're called palbociclib, ribociclib, and abemaciclib. And as you can see, if you look at the lower part of this picture, it helps in the cell cycle growth, or stops the cell cycle growth in these cancer cells. So current usage for CDK4/6 inhibitors is in metastatic breast carcinomas, where it has actually changed the way we treat patients and avoid chemotherapy or delay systemic chemotherapy in a significant number of patients. A license in using ER positive, HER2 negative tumors, and also in combination with endocrine treatment. So endocrine treatment becomes the backbone, and the CDK4/6 inhibitors are used on top of that in metastatic setting. So all these drugs, palbociclib, ribociclib, and abemaciclib, they went through clinical trials looking at whether we can use that earlier in their disease journey, and can we avoid or delay the requirement of any metastatic, delay the use of any metastatic treatment later on. So again, going back to the trial again, so that the trial looked at adjuvant treatment in a hormone positive, ER positive, HER2 negative tumor, but they took the high risk patients who are node positive, and then looked at so the standard treatment for these patients would be, or before this trial, would be looking at giving chemotherapy or endocrine treatment, radiotherapy based on what surgeries that they've had, and then starting them on maintenance endocrine treatment for up to 10 years. So this trial looked at randomizing between endocrine treatment on its own versus adding the CDK4/6 inhibitor abemaciclib for 2 years. And the trials shown that at the end of 2 years, so you can see that the hazard ratio is 0.72. So there is around a 28% decrease in chance of distant relapse by use of these drugs. So it is quite possible that this will be, will be licensed and probably will be used in our years to years forward. There's also a question about whether the patients will take this up because the side effects that the potential that they may have, which is mainly diarrhea that they could actually get, and also the cost involved in the setting. How much we will be able to adopt that is always a matter of question. A second trial I want to actually talk about is a radiotherapy trial. Sorry, this is actually again about this trial, the abemaciclib trial, showing that almost all of the subgroups did get benefit from use of abemaciclib. So the second trial is, it has been a lifesaver, to be frank, over the last year. So it's a UK trial called Fast Forward, which looked at reducing the amount of the fractions of radiotherapy, or it's hypofractionating the treatment with larger doses per fraction. So rather than, so standard has always been in UK based on a trial called START trial. Again, 40 gray and 15 fractions has been the standard radiotherapy schedule. But this trial looked at using 5 fractions, giving 26 gray in 5 fractions or 27 gray in 5 fractions, and around 4,000 plus patients were randomized in this trial with around 100 UK centers. They selected patients who are node negative and so early breast cancer node negative patients. And they will, the endpoint of the trial was to look at ipsilateral relapse. And what the trial, again, this trial was published in May 2020, so timely with the COVID pandemic that we were having. And what the trial showed that the 5 fraction treatment was non-inferior to the standard 40 gray and 15 fractions, where the patient had to come in to have radiotherapy daily for 3 weeks. And it's also over that 5-year period, it is safe in terms of normal tissue effects. Again, the concerns about the trial is that it's only a 5-year follow-up that we have got for this trial. So with an early breast cancer, one could argue that you need more follow-up before we can say the safety of this trial. But I will come to that a bit later on. But we in UK, we have actually adopted this trial very quickly, given the pandemic that we've actually we're going through. The third drug that I want to talk about, and the third trial that I want to talk about, is a trial called Catherine trial, which uses a antibody drug conjugate called Kadcyla. So we're now moving from the ER positive HER2 negative to a HER2 positive breast cancer circumstances treatment. And again, Kadcyla was the first antibody drug conjugate. So practically what it has got, it's got the Herceptin along with a chemotherapy called DM1, which is attached to it. What the drug would do is, obviously, it will come and bind to the HER2 receptors on the cell surface in HER2 positive breast cancer. And obviously, there is a Herceptin mediated anti-tumor activity, and also that would deliver the DM1 which, inside the cancer cells, which is a microtubule inhibitor. Again, use of Kadcyla has been well documented and well, recorded in metastatic HER2 positive breast cancer, which has been used as standard these days post progression and first line of HER2 based treatment. And also, if there's a relapse in completion of adjuvant Herceptin, the UK guidelines is to use Kadcyla. So the trial here looked at using, again, can we use the drug early to try and reduce the chance of metastatic development? And published in 2019, the trial looked at people who've had HER2-positive breast cancer who've had neoadjuvant chemotherapy and HER2-directed treatment, followed by surgery. It looked at whether the patient had a complete pathological response or having an residual disease, and based on that, randomizing it between Herceptin versus Kadcyla. And what it actually showed was if you use TDM1 in patients who've got have got residual disease, the invasive disease-free survival goes up by more than 10% in 3 years, so which is quite a significant difference. And I think this is one circumstances where we've actually, would start to argue with the surgical colleagues saying that please don't operate before the patient has all the ERPR and HER2 results, because this trial kind of describes the circumstances where you can modify the treatment that we can offer, or personalize the treatment that we can offer for the patient. So as you can see, there is a 10% difference in invasive disease free survival if you've got a residual disease after the neoadjuvant chemotherapy and HER2-directed treatment, and where by changing this you can improve their survival. So this is again going to be a significant, what can I say, algorithm changing trial. I hope it'll be actually accepted by a majority of the population. Yeah. So moving on to from early breast cancer to metastatic breast cancer. So around 1/3 up to 40% of people will develop metastatic breast cancer or relapse after the primary treatment, and the common sites include bone, lung, liver being the most common, these three being the most common, and also soft tissue disease. Brain is a common site of relapse, especially in triple negative and HER2-positive breast cancer. The aim of treatment in these settings is obviously slightly different from what we've actually had before. It is, I would say it's a misnomer to say that once we have metastatic disease, we're not aiming to improve the survival of the patient. It's not a death sentence that's been actually given to the patient, because with the improvement in the treatment, we can actually improve the survival. But along with it, what is quite important is to maximize their quality of life. So that becomes an important part when we are looking at how we're selecting the treatment for metastatic breast carcinoma patient. And median survival for these patients actually goes into years, especially if you've got an ER-positive, HER2-negative tumor. It's not surprising if they would actually live for decades. Again, the treatment algorithm in metastatic breast carcinoma would go back to looking at the ERPR HER2 status of the patient, and also the site of metastasis and the disease burden need for rapid response. With the circumstances that we now call as oligometastatic disease, where you have small volume metastatic disease that's available, present either as a lung metastasis or bone mets or even liver lesion, we now know that in an oligometastatic situation, by going aggressively and treating those lesions with stereotactic radiotherapy or even surgical resection, we can hope to improve their survival much more. So the disease burden becomes an important part of it. And also the need for rapid response. When we're looking at endocrine treatment versus chemotherapy versus any other treatment, disease burden also is important, because if we are at a circumstances where there is risk of visceral crisis, i.e. where there's significant amount of disease in liver or other parenchymal areas, we do want to try and get a rapid response and think about using systemic chemotherapy prior to endocrine treatment. Again, I'll go through that. And obviously, patient factors comes into play. So this is just another algorithm for metastatic breast carcinoma in the ER-positive, HER2-negative treatment. As I said, if you have got a situation, the endocrine treatment is an important, or is a preferred treatment option, unless we actually have a visceral crisis, situation with visceral crisis. So, and then the endocrine treatment is based on the menopausal status of the patient, and also if they are premenopausal, perimenopausal, we know that ovarian ablation can be useful. Along with endocrine treatment, what has changed is the use of CDK4/6 inhibitors. So CDK4/6 inhibitors, along with endocrine treatment, has practically doubled the amount of time that we can control these disease. And there are other treatment options that are available, including aromatase inhibitors, these endocrine treatments like aromatase inhibitors or tamoxifen, going towards drugs like mTOR inhibitors like everolimus. Okay, so when we start using the CDK4/6 inhibitors and endocrine treatment in a first line or a second line setting, so again, let's take a step back. Thinking about circa 10 years ago, what we would have done was a patient comes with metastatic disease, which is hormone sensitive, HER2 negative, with bone mets or small volume extracranial systemic mets. We would want to think about putting them on endocrine treatment on its own. But now we know that by using CDK4/6 inhibitors like palbociclib, ribociclib, we can improve their progression-free survival and overall survival, practically double that. So the question then comes, what next? Once they've actually gone through that, should we go through to chemotherapy? Again, these first-line treatment, are they actually as effective as chemotherapy? So there has been some trials comparing the CDK4/6 inhibitors versus chemotherapy with, say, capecitabine, and that's shown to be not significantly different. So you can use the CDK4/6 inhibitors and try and avoid people going through systemic chemotherapy to an extent, or delay the need for treatment for an extent. But previously, if you were given endocrine treatment, on progression, you would switch to other endocrine treatment or think about chemotherapy. But once they've gone through CDK4/6 inhibitors, is there, what is the next step? That's always a question that needs to be answered. Again, looking at the molecular nature of the tumor becomes an important part here, because the next kid in the block is PI3 kinase inhibitors in metastatic setting, which is the first trial that I want to talk about in patients with metastatic breast cancer. So alpelisib is one drug which is used in PI3 kinase inhibitors. So as you can see, it's the PI3 kinase AKT-mTOR pathway that can result in increase in transcription factors and proliferation of the tumor, can be inhibited, especially the alpha subunit of PI3 kinase is important in breast cancers, and alpelisib can actually block that, resulting in improvement in survival. So there were two trials that were done. The first one was a SOLAR-1 trial, which looked at use of alpelisib in PI3 kinase mutated patients, and the second one was looking at a trial called BILey, which has been recently published or discussed in ESMO as well, which is a phase 2 trial, which looked at, one of the arms looked at, can we use PI3 kinase inhibitor post CDK4/6 inhibitor usage. Going through the first trial, the SOLAR-1 trial, SOLAR-1 has actually shown that adding alpelisib versus placebo along with with Faslodex in PI3 kinase mutated cancer patients, and roughly the number of patients metastatic breast cancer with PI3 kinase mutation would be in the range of around 33 to 35%. And in those settings, you can see that there is an improvement in progression-free survival in those patients. Seem to have actually missed putting the PI3 kinase, the data from BILey trial as well here. So with what the BILey trial showed, that there was still a response that is actually seen in up to around 20% of patients where they got a response, and also a clinical benefit was seen in nearly 45 to 47% of patients who've had PI3 kinase inhibition, PI3 kinase mutation, post CDK4/6 inhibitors. So it is possible that the algorithm of treatment might actually change based on whether the patient has got PI3 kinase mutation in their tumor. So this hence becomes an important trial which might change our practice down the line. The next trial, again moving from ER positive HER2 negative to HER2 positive tumors, is a drug called tucatinib. Tucatinib is a small molecule tyrosine kinase inhibitor similar to a previous drug called lapatinib. And what tucatinib has shown is that when you use tucatinib in combination with placebo or against placebo, so the drug used was, they compared those with capecitabine, and that showed an improvement in median duration of control and survival with a hazard ratio of 0.66. What is interesting with this drug is that when we look at patients with brain metastases as well, there seems to be an improvement, a benefit for patients. It's probably the first drug in breast cancer which is shown to have an effect on brain metastasis, which might over time lead us to delay treatments like whole brain radiotherapy or stereotactic radiotherapy to patients with brain metastasis from breast cancer. We're seeing that more with lung cancer these days, and also in melanoma, where we can see that some systemic treatments which has got an effect in intracranially can delay the use of radiotherapy or even whole brain, stereotactic radiotherapy or whole brain radiotherapy, and thereby reducing the chance of long-term cognitive impairment for these patients. So this is an exciting drug in that aspect. And the last trial I want to touch on, going to triple-negative breast cancer. As we all know, people talk about immunotherapy in these settings, and breast cancer was one subspecialty where immunotherapy has never shown to be significantly useful. So the first trial, which has now got approval to use, is using an immunotherapy, a PD-L1 inhibitor called atezolizumab, with Abraxane in triple-negative breast cancer as first-line metastatic treatment. And the trial recruited around 1,300 patients, and in patients who've got PD-L1 positive tumor, the overall survival was actually increased by around 10 months by using the atezo-Abraxane versus the standard chemotherapy. So again, we've got license for using atezo-Abraxane, but only in PD-L1 positive tumors. So that's what I wanted to talk about, all the important trials which I thought would change practice for us over the next few years. But we did that, all these things came up, and then COVID-19 hit UK hospitals. So the first, the patient was diagnosed in Royal Berkshire Hospital, and even before that, in fact, in Mount Vernon, there was a false alarm in my hospital. There was a false alarm where we thought that staff was positive after her return from Europe for a holiday, but that was found to be negative ultimately. So the COVID-19 obviously brought about a lot of uncertainties for us. For the first time since working in UK, the healthcare resources, the uncertainty regarding healthcare resources, came to light. Would radiology be available for us? Would theaters be converted to ITU? So would there be any theater list? What if the staff becomes ill? Who's going to look after the patients? Can we deliver chemotherapy and radiotherapy, safely? All those uncertainties came up for the healthcare team and for the patients as well. Is it safe for me to go to hospital? And if I have chemotherapy or radiotherapy, the questions they were asking is, would it weaken my immune system and would make me more prone to the side effects of COVID and causing death? And again, if I have to shield physically, what do my husband and children do? And again, another common question that came up from the patient, my mother lives alone, can I see her during her treatment? So all these uncertainties came up, and we had to rationalize the services that we had. And luckily, the national guidelines were brought in, decisions were taken in a national level with the NHS England, and also the Royal Colleges were significantly involved, with also Association of Breast Surgeons and UK Breast Cancer Group. And guidelines were brought up, which were quickly adopted across the country. But what is extremely important was, what I found was extremely good was that we are actually documenting each and every changes from pre-COVID treatment plan. If a patient has had a different treatment decision made based on COVID, that is recorded, and it goes into an audit on a national level. So the question is, are we doing any harm for these patients? It's quite important for us to know about it. But with the recent data that's come up from China and Korea, has actually suggested that maybe systemic chemotherapy does not actually increase the risk for patients with COVID-19. But one thing that's happened was breast screening was suspended. So obviously we lose that benefit. And also the concern for us is about, once the screening has now been reopened, are we going to get much more advanced patients coming in who didn't attend the screening, and early breast cancer was not picked up. Surgery had to be prioritized. So patients with small ER-positive breast cancer, surgery was deferred and started on primary endocrine treatment, and delay the surgery till that peak of COVID was actually over. Immediate breast cancer reconstructive surgery was cancelled, and we have seen increased use of mastectomy, where patients understood that, okay, if I have a mastectomy, I may not need to go through radiotherapy, so I don't have to come into hospital for 3 weeks or a week. So increased use of mastectomy was actually noted as well. With the radiotherapy, the fast-forward trial that I've explained before was a lifesaver. This was quickly adopted, reducing the visit to hospital from 3 weeks to 1 week. With systemic therapy, there was a major impact on the use of chemotherapy, especially in the initial phases where even the clinicians were uncertain regarding what is the right thing to do. As we know, with systemic treatment, they've got multiple visits, and also there was a question about how do we social distance these patients in the clinic and also in the chemotherapy unit. What is the risk of neutropenia-induced immune compromise and risk there? So people have looked at alternative treatment strategies, like if you've gotten hormone-sensitive tumor, even putting them on endocrine treatment for a period of time, as long as they are not known to be endocrine resistant completely. Switching to targeted treatment as anti-HER2 treatment and avoiding chemotherapy. Switching to less neutropenic chemotherapy regimes than the standard that we would be using. And increasing the number of GCSF usage to reduce the risk of neutropenia. And also, but we had to take some decisions in some patients where treatment decisions been made to stop the treatment. This was only in a group of patients, like patients who are elderly and were undergoing systemic treatment, to prevent them from coming into hospital every week, every 3 weeks for treatment. Logistical changes have been made where virtual clinics were mandated. We're using telephone clinics and video clinics, which is now becoming the norm, which makes much easier for the patient, but not always not in all situations will be useful. Oral prescriptions were started to be delivered home, and we've started testing every patient who is coming, who needs to attend the hospital for treatment. For clinical staff nowadays, we are having COVID testing on a weekly basis so as to make sure that it's safe for us to continue working and seeing patients who could be immunocompromised. In order to limit the damages, once the peak was over, or the first peak, I should say, the treatments which were withheld have been restarted, and along with that, a cancer awareness campaign had to be done to reassure the patients, to say that the hospitals are safe. We're testing patients, we're testing staff. So that was an important part, I would say, to improve that patient confidence. So we've restarted the trials which were on hold, and the screening has been restarted. The question then comes up, as I talked about the national audit where patient management and outcomes is being recorded and reviewing. Do we need to actually have additional monitoring for these patients who received non-standard treatment due to COVID? We don't know, but that's always a question that needs to be thought about. There were positives in between where we thought that we could never adapt that quickly, and it just managed to move quickly to adapt when it's required. Taking on the fast-forward trial, for example, that happened within weeks, and also setting up technological advances for video clinics and telephone clinics has also been set up in a safe way. And some treatment changes that we've actually made have been positive and probably will be here to stay. And we understood that there is different ways of practicing, and we can actually resolve staffing crisis in a different way. And these can be valuable for patients with chronic illnesses. With that, I'd probably stop my talk, and thank you very much for staying back and listening to me. I'd be happy to go into discussions and questions here.
Thank you, Dr. Anup, sir, for that brilliant session. Over to Dr. Abraham Samuel for the moderation.
Thank you, Dr. Anup, for that excellent coverage of all aspects of management of breast cancer. So far, I am not seeing any questions from our audience. So I would like to ask one question.
Sure.
What is your strategy of managing of the axilla in early breast cancer? Do you routinely use sentinel lymph node, or you use what technique you are using, and what about axillary sampling? What is your current strategy for managing?
So standardly, what we are doing in UK is in circumstances where there is no axillary, the clinically, there's no lymph node seen in the axilla, clinically or radiologically, we are going with sentinel lymph node biopsy. So at the time of the surgery, they will have sentinel lymph node biopsy using the blue dye and also the radiolabel dye, the dual technique, and sample the lymph nodes, whatever is actually there. And in patients with node positive circumstances, we are going for an axillary clearance. There is, with the adoption of neoadjuvant chemotherapy more and more, there's always the argument of actually looking, should we be doing sentinel lymph node biopsy pre-neoadjuvant chemotherapy, or is there any role of doing sentinel lymph node biopsy after the neoadjuvant chemotherapy at the time of surgery? Previously, we used to do sentinel lymph node biopsy in neoadjuvant setting before we started the chemotherapy. But then with the current data, we've actually seen that, so if you use dual technique, we can probably get around 85% of 80–90% chance of positivity or reliability, even in post-neoadjuvant setting. So, so in a situation where we don't have any ultrasound or radiological or clinical axillary lymph node, we are now moving towards using sentinel lymph node biopsy post-operatively. Post-chemotherapy. I can see.
Okay, thank you for that. We have a question from one of your audience. The question is, how frequently you see BI-RADS 4 lesions? I think it is what is mentioned is non-palpable. I mean, I think it is a screening, screening. And how relevant is the KS67 index once you do in the biopsy specimen, and does it change the management? That is his question.
Okay, so with the Ki67, we are, especially. So there is an argument. So Ki67, the problem with Ki67 is that it can be quite subjective. So Ki67 index, if it's in a center where we're not used to using Ki67 more, there is an argument that might actually create more confusion than actually any benefit that is actually needed. But centralizing Ki67, assessment centralizing Ki67 assessment can be quite important. And what we are doing nowadays is that, especially in clinical trials as well, we are using Ki67 on a centralized basis. And that can be used, especially when you've got a luminal A versus a luminal B breast cancer. That could be a decision maker in terms of chemotherapy. But with the use of multi-gene panel like Oncotype DX, we've actually kind of started to move away from those Ki67 usage as well. So it's a double, it's a mixed picture that we're seeing. So some centers. So the question is, do we have are we comfortable with the Ki67 report from our center because of the subjective nature of it, or should we be using things like a multi-gene panel, which might give a better outcome as such? With initially we were talking about the screening, the BI-RADS 4, the non-palpable BI-RADS 4 lesion. It is. We usually actually, obviously BI-RADS 4, we've got different sessions like 4A, B, and C. With when you've got a 4A or a lower suspicion, we tend to go for a repeat assessment first, a repeat imaging assessment first. But if you've got a higher suspicion or moderate suspicion of malignancy, then we would actually go for a biopsy in those settings, or even going through an MRI first.
One more question, Praveen. what are the indications of giving radiation to the axilla after axillary clearance?
Okay, so the axillary clearance, post-axillary clearance, we've actually moved away from using radiotherapy to axilla unless and until the surgeons are clear that they have actually left macroscopic disease in the axilla. And that is mainly because of the risk of, in those patients where we've got large number of axillary disease, the risk of, or the risk of their disease would be more from systemic, concern with more systemic metastasis than actually local relapse. So unless until there is a higher chance of disease relapse in the axilla, which is denoted by the fact that we've got, say, macroscopic disease residual that's actually left in the axilla, we tend not to go back and give radiotherapy. We have started to use radiotherapy in settings where we're not, we've got, say, central lymph node showing 1 out of 3 lymph nodes in a patient who does not want to go back and have surgical clearance. We've started using axillary radiotherapy. But again, that's the second best treatment, I would say, rather than going for surgical clearance.
I'm not able to see any more questions. Okay, I think one more question is there. What is the technique of doing a biopsy for non-palpable subcentimeter bilateral for lesions in your setting?
Oh, so they normally go for a vacuum biopsy, if I'm right. I may be wrong here because I usually leave it to my surgical colleagues. Who's that? Abraham. Abraham's. So I would leave it to colleagues like you, Abraham, in terms of how to select that in a technique. What I understand is that they would actually go for a vacuum biopsy, if I'm right. I may be wrong there.
Do you remove level 3 nodes routinely for a after lymph node dissection? That is another question.
So they do try and actually remove, especially if you've had a neoadjuvant chemotherapy. We do, they would go for a level 3 clearance. If they've only had a central lymph node biopsy proven, say 1 out of 3 lymph nodes, and we are going for a clearance, they don't go for a level 3 nodal clearance.
One question from myself. What is the indication of neoadjuvant immunotherapy in triple-negative breast cancer? Do you routinely practice that?
No. So I think we're not actually doing neoadjuvant immunotherapy at all in triple-negative breast cancers. We are only using in breast cancer at the moment. The only use of immunotherapy that we're doing is in first-line metastatic setting. It's the trial that I showed about atezolizumab and Abraxane is what we're using. And there is some, some situations where we use pembrolizumab as well, but all in metastatic, but not in neoadjuvant yet. There was a clinical trial that was going on, Impassion, can't remember the number, so which was looking at neoadjuvant use, but it's not been reported yet as far as I'm aware. I can see another question from Abraham. CDK receptor treatment is a paradigm shift, but how costly is it? That is an important question, Abraham, because all these drugs, these targeted drugs, are quite expensive. And as far as I don't know what the cost is in India, but I think if you're trying to get that privately in UK, I think we're looking at probably around 1.5 to 2 lakhs Indian money per month.
Hopefully there are no more questions.
Okay.
Thank you, Dr. Anup, for that wonderful presentation, as well as answering all those questions. Now we'll hand over the mic to Dr. Jacob Jesselin.
Yeah. Can I just thank all the organizers, including yourself, Dr. Abraham, Dr. Jacobson, and also Dr. Philip, who actually invited me. and all the people who work behind the scenes to make this possible from the Believers Hospital. And more than that, all the 33 participants who I can see who, we've actually run over time, but still they managed to stay back and listen to the talk. Thank you very much for all of you.
Thank you, Dr. Anup. Just off the hat, since we have our medical students, few of them in this session, I would like to ask you, what would be your 1, 2, 3 tips for medical students?
In terms of management of breast cancer?
No, in terms of career advancement.
Oh, well, that's a tough question, isn't it? Because I think first and foremost thing is, I would say the most important thing is to attend the clinics, because I think that's the first and foremost thing. Don't, when you're looking at your sessions, teaching sessions, or even clinical sessions, I would say, clinical sessions is so important, whether it is actually in the community, community that we actually go, or like what we call as SPM, isn't it? That's what we call it. Or whether it is a pathology session, just being attentive in those sessions, that's probably the first and foremost thing I'd say. The second thing is, your interest would change over the years, because to be frank, while I was in med school, I wanted to be a surgeon. So, and I would say I'm bad with knives. So I'm glad that I'm actually where I am and not a surgeon. So it's explore each and every subject that you're going through. And then the third and most important thing is just try and be updated. So nowadays, we don't, it's not the textbooks, isn't it? It's being updated with what's actually going on in the world in terms of management. It's easily available to all our fingertips in the phones and through the internet. So being updated about about the current development is probably the 3 things.
Thank you, sir. That was pertinent. And in fact, since you were weak with knives, you went on to train in gamma knives and cyber knives.
Luckily, they don't involve any knives.
I know. I know. All right. So thank you so much. That was an amazing session, and it's a great privilege that we got to hear from you. Looking forward to many more sessions from you, Dr. Anup. Thank you so much. Thank you so much for your precious time. Thank you.
Thank you.
Yeah, and I would also like to thank our moderator, Dr. Abraham Samuel, for taking his time off and coming on and ably moderating the session. Thank you, Dr. Abraham Samuel, sir. Thank you.
Thank you.
So, and I would also like to thank all our participants, just like Dr. Anup sir just mentioned. Really appreciate your commitment to learning and excellence, and rest assured you will reach where you want to. So until we meet you with another wonderful session, let's sign off from Believers Church Medical College. Thank you.